So I would now like to welcome Dr. Keyur Patel, an Associate Professor of Medicine from the University Health Network in Toronto. Dr. Patel received his medical degree from the University of Southampton and completed his clinical fellowships in internal medicine and gastroenterology hepatology in Western Australia. He completed his postdoctoral research fellowship in clinical and translational research in viral hepatitis at Scripps Clinic and Research Foundation and Duke Clinical Research Institute. His research interests include early phase clinical therapeutic trials for viral hepatitis and fibrosis, and the development of biomarkers of fibrosis. Welcome, Dr. Patel.
Thank you for that kind introduction. Thanks to the meeting organizers, chairpersons. So the topic I was charged with was talking about liver fibrosis staging in hepatitis C, which has had a very evolving life, shall we say, over the last few years. And while I was given this topic, I thought, oh my God, this is, I wonder who'll go, wonder what will be, will lose its interest first. Either the Prime Minister of Britain goes first, or fibrosis, liver biopsies for hepatitis C will go first. But I think, if I did a survey of everyone in this room and how many hepatitis C biopsies specifically have been ordered in the last couple of years, it'll be very, very few. So again, changing times. So the objectives are really to talk about biopsy limitations. I know many of you folks are familiar with this topic, but because we've got a broad audience, I have to really talk about biopsy limitations. Then increasing use of non-invasive methods for fibrosis staging. We saw in the last talk by Dr. Al-Sarrag, prediction modeling on HCCs, etc., based on some of these non-invasive methods such as FibroScan. But what I wanted to spend a little bit of time was assessment of fibrosis progression and regression, which is really relevant as to how we follow our post-hepatitis C, post-cure patients, for example. So limitations of liver biopsy, I've been showing this slide for many, many years. We know it's invasive, morbidity and mortality. There's observer variability. There's sampling error. You only sample a very tiny bit of the liver, 1 in 50,000th of the liver with a typical needle biopsy. And then you get discordance of one stage, depending on which bit of the lobe you get. That was based on a laparoscopic biopsy study done many years ago now. It's costly, contraindications, and we know fibrosis and fibrogenesis is a dynamic process, but what we get with the liver biopsy is a single time point static view of what's happening. Now, these are an example of perfect biopsies. Anyone in this room can categorize these patients by the Medivir score into either F1, F2, F3, or when you start forming nodules, F4. So that's easy enough for any person to do. However, the real world is this, a hodgepodge of varying sample sizes, fragments, and we ask our pathologists to give us a score and some idea on inflammatory activity, and that's based with hepatitis C. Nowadays, when we do biopsies, it's to exclude other reasons, and we're expecting them to give us a diagnosis based on varying sample quality. So here's an example of where sampling comes in. If you look at this biopsy, it's probably a Medivir stage 3 or an Ishak-5, which is incomplete cirrhosis. So depending where you go with your needle, this could give you, this could capture a nodule and give you a Medivir 4, for example. If you go here, you're not capturing any of the portal tracts, and a little bit of fibrosis might give you a F1. If you go here, this could be an F2. So again, sampling error is inherent to our accuracy for biopsy. And this really nice modeling study done from Beth Israel and Johns Hopkins group a number of years ago showed us the limitations to diagnostic biomarker development. And this was a modeling study which looked at the ideal circumstance, basically, where you looked at biopsies and just trying to get a semblance of F2 to F4 across a range of hepatitis C disease prevalence. And so if you had the best case scenario with a disease prevalence of F2 to F4 of 40%, which is typical of tertiary centers center practices where most patients did have significant fibrosis just because of the referral bias. And he looked at sensitivity and specificity of 90%, which is really the benchmark for a diagnostic biomarker. The perfect marker would not exceed an AUROC of 0.9. And for those of you not familiar with an AUROC, it's a measure of an accuracy, broadly speaking, of a test. And a test which gives you a score of 0.5 is no better than flipping a coin. And a perfect marker is really a test of 1.0. So with those kind of high standards of sensitivity and specificity of 90%, the perfect marker, just purely because of the limitations of biopsy, could not get above 0.9. So keeping that in mind, what do we use for non-invasive staging of fibrosis? Clearly, we don't do biopsies for Hep C. We do them for other reasons, of course, nowadays mostly for fatty liver disease and other chronic liver disease. So we use our clinical impressions, take into account various demographics and phenotype of the patient. We can use indirect markers which reflect inflammation, which we think is a key driving process in fibrogenesis. We take into account these simple markers, which many of us get as part of routine clinical practice. Apolipoprotein is a little bit more sophisticated, but again, routinely available. Or we can pay for some of these more direct markers, which reflect extracellular matrix remodeling and turnover. And then we have newer imaging techniques as well. So these are broadly speaking, the basis of non-invasive staging of fibrosis. So let's look at simple markers. AST platelet ratio index, APRI, which many of you are familiar with, developed in 2003 from the Michigan group. Again, you get a score of less than 0.5 or greater than 1.5, telling you can split patients with significant fibrosis. Slightly higher thresholds give you a cirrhosis index threshold as well. And then many of you are familiar with FIB4, developed from the APRICOT trials in HIV-HCV co-infection in 2006, and rapidly adopted into Hep C monoinfection, now into NASH. And you can see, again, simple parameters, age, AST, platelets, and ALT, giving you a score, two indices, two index thresholds, giving you a risk prediction of those stages, basically. So greater than 3.25, equivalent to F3 to F4. However, when you fall into these indeterminate ranges, so take FIB4, if you have a score between 1.45 and 3.25, that's indeterminate, and that happens in about 30 to 50% of cases. So again, useful when everything fits in and everything agrees, but reality is you get indeterminate scores in 30 to 50% of cases. So around 2001, folks in France developed the Fibro test based on a number of simple markers, basically, and came up with a Fibro test and FibroSure, which was then available in the US in 2005 through LabCorp. And again, their idea was to have a continuous index, a regression index, basically, which gave you a score from 0 to 1.0 and put you into a risk prediction fibrosis category. But again, you can see, if you've got a score of somewhere between 0.32 and 0.48, you're F1 to F2. And in those days, the threshold for treatment with interferon therapy was F2. So, you're kind of stuck doing biopsies again in these indeterminate cases, even with Fibro test. Certainly a lot more activity in those days with the development of a whole bunch of biomarker panels. Most of these were the top four are certainly proprietary marker panels and still available. ELF is not available in the ELF and Fibrometer are available in Europe, but not so much in North America. And HepaScore again was marketed by Quest Diagnostics for many years, not available. FibroSpec 2 still available through Prometheus Labs, again charging $250 to $300 per patient and giving you AUROCs, which are no better than essentially the simple markers I showed you, such as FIB4 and APRI, with the without the indeterminate scores, though. But again, and I haven't got time to show you all the data in comparisons with these different marker panels. But again, no different to Fibro test. So this is just not so much to go through each test, but basically all the tests agree, and there's no one test that's better than the other for diagnosis of F2 to F4 or F4. Again, the simple and complex markers seem to perform a little bit better for more advanced stages of disease. So if you're looking for F4, there's a little bit more reliability in these tests in that regard. We do have ultrasound methods. Many of you folks know about FibroScan, and some of you have other ultrasound elastography methods, such as shear wave, available at your centers. And again, this relies on physical properties of the liver tissue, the idea being the stiffer the tissue, the shear wave propagates at a much quicker velocity, and this is calculated into an equivalent stiffness score. There are differences between FibroScan and ultrasound elastography, the main one really being the newer methods such as ultrasound elastography rely on acoustic shear wave methods, either propagation of an acoustic shear wave or displacement of tissue. But it does give you a B-mode image, which allows you potentially also to consider screening for HCC, etc. And you get a much larger region of interest than the FibroScan. Lots of confounding factors with FibroScan. You have to really know the ALT. I see patients with FibroScan, being done in patients who have hepatitis B flares or come in with autoimmune hepatitis. Again, you will get a large number purely because of the inflammatory aspect resulting in increased stiffness. Patients are often not fasted. They get FibroScans in the afternoon after having had a big lunch. And while we use this to our advantage in the old days to qualify people into F2 when they were really realistically F1, I used to go and tell them to go and have a big meal, run up the stairs and come and have their FibroScan, and increased blood flow to the liver postprandially was enough to push people into an F2 category. So, but for a realistic value, you should really get them to be fasting for about 2 or 3 hours. Cholestasis obviously increases it, and other factors, as you can see there. Basically anything which results in increased blood flow, and even congestive hepatopathy will result in increased stiffness value. So consider those when you make assessments in these patients. So again, broadly speaking, comparable to serum markers for diagnosing significant fibrosis. Across the board, many studies, and a little bit better for cirrhosis. Compared to serum markers, but again, it's really pulling teeth, basically trying to say this one is definitely better than any of the serum markers. And certainly the European guidelines on non-invasive testing told us that basically, if these tests agree, that's great. There is added cost. Not everyone has access to a FibroScan or even FibroTest or any of the other marker panels in the US. It's very insurance-driven and dependent. So again, where there's discordance, liver biopsy is still recommended. And this is really around the time the DAAs were coming in, so I'm not sure about the role now. And really, there's no validation of this this algorithm post SVR and following patients. So what I wanted to spend the rest of the time on was really talking about adjacent fibrosis stages, longitudinal assessment, and how we can use these tests for regression, and are they useful? So when you look at FibroTest, and you look at the box on the right, and many thousands of patients, and this study is from a number of years ago, so this has increased since then. And you look at the AUROC values, and this is asking the FibroTest to split between different stages, so F0, F1, or F2 to F3. Can this test differentiate between these adjacent stages? These are all biopsy-proven patients. And you can see across the board, irrespective of your major chronic liver disease states, the diagnostic accuracy of FibroTest is, again, not that much more than essentially flipping a coin, as I told you, with an AUROC of 0.5. So, again, so there's got to be something better, right? So we thought, the current markers, when you look at the progression of fibrogenesis from F01 all the way to hepatic decompensation, the current markers kind of use inflammatory markers and combine it with some extracellular matrix, turnover proteins, and some markers of hepatic function in an all-encompassing fashion to give you an idea of what's happening at each stage. And clearly, that's not going to work. And we know from the biology that basically different aspects of fibrogenesis and repair are happening at various stages of fibrosis. So lots of modeling going on in the early fibrogenesis pathway, early fibrogenesis stages, angiogenesis in the moderate stages, and then regenerative pathways are very active in the F3, F4 stage. So we thought, let's undertake a very expensive study and put 37 candidate biomarkers on a custom multiplex ELISA. This custom-made chip cost $1,000 per patient. We had, as you can see, well over 900 patients in this study, which included 100 controls. So essentially $1 million study, which gave us some nice proteins and expressed candidate biomarkers for the different stages, but you can see the AUROCs were, again, no better than what we have. And when we compared it to fibro tests in each of these cohorts, again, not much better than what we already have. So, but again, lessons learned. We thought, well, let's look at fibrosis regression then. And this is from hepatitis B. So this is the 102, 103 registration trials, the last real studies to do biopsies for hepatitis B. So we have paired biopsy data from this large registration trial done more than 10 years ago now. So, and if you remember, patients with Ishak 5 or 6, which is cirrhosis, after suppression on tenofovir, these patients, a large proportion of these patients, 71 out of 96, actually had regression from cirrhosis back to a non-cirrhotic state. So, this group looked at APRI and FIB4, very simple markers as I showed you. And again, there was no correlation between APRI and FIB4 and fibrosis regression, including those cirrhotics who were no longer cirrhotic at the end of the study. It didn't correlate with patients who didn't change. It didn't correlate with patients who progressed. So basically, what good is APRI and FIB4 for following patients with changes in fibrogenesis with suppressive therapy such as tenofovir? Well, none. And in fact, patients with persistent cirrhosis were incorrectly classified by APRI, and the same with FIB4, incorrectly classifying patients with Ishak 4 to 6, so that's Medivir stage 3 to 4. And importantly, as I showed you earlier, up to 60% of patients also had indeterminate results. So really no utility in following or using these tests and following patients who have supposed regression of fibrosis. So what about fibro tests? Again, this is from the registration trials for hepatitis C, the PEG interferon alpha 2B studies from 2002. And again, if you just look, these are based on paired biopsies at the time we did biopsies at week 72, 6 months after 48 weeks of interferon therapy. And this shows, you can see the patients varied according to what happened to that biopsy. Patients either increased their fibrosis stages or decline. And this study also showed us that patients with cirrhosis could regress. Hep C cirrhosis could regress from a cirrhotic to a non-cirrhotic stage as well. But when you look at fibrosis, fibro tests to assess these changes in fibrosis stage, you can see there was really no change. And there's with the eye of faith, you can see there's a general decline in fibro tests, irrespective of what happens to your actual fibrosis stage in biopsy. So can we use FibroScan? We seem to use it because it's a point-of-care test that's available everywhere. And if your tertiary center happens to have bought it or acquired it, you can use it every 10 minutes if you want. But again, we know what the thresholds are moving forward, and this is where I would urge caution is, we know we have established thresholds for F2, F3, F4 based on lots of data, basically. So we know what the thresholds are moving forward, but now when we apply it to patients who've been cured and we're trying to assess regression of fibrosis, we do not know what the thresholds are. And that's really important. So do not fool yourself into thinking that someone with a 12.5 who was cirrhotic and now has a FibroScan value of 8 or 9 is no longer cirrhotic. We do not know what the thresholds are going back because, again, we don't do biopsies post-SVR. So this is a question which may never be answered. This study from Italy actually did do biopsies, and they did biopsies. These are cirrhotic patients post-SVR biopsied 4 years later, and they found that 60% of patients actually, as you'd expect, actually had a regression post-SVR to a stage F1, F3. And of course, these were really well-compensated patients. They'll go interferon therapy. So, but again, biopsy 4 years later did show regression of fibrosis. And even this is looking at collagen morphometry, which is a quantitative measure of fibrosis in the liver biopsy. And it showed that even amongst the F4 patients, there was a decline post-SVR in patients who still remain cirrhotic on the biopsy, but you do see some favorable changes in reduction in collagen. Now, when you look at FibroScan, they had FibroScan available in a proportion of these patients, and they used a threshold of 12, and they found that, yes, liver stiffness correlates with morphometry. And 8 out of 9 patients with a score of greater than 12, yes, they did have a biopsy of stage 4. Remember, this is like 3 or 4 years afterwards on the second biopsy. But importantly, 5 out of 24 patients who still had cirrhosis on their second biopsy had a lower FibroScan score. And there are other studies I can show you, but I don't have time to show you in this regard. So you will see some declines in FibroScan. You will see some declines in FibroTest. APRI and FIB4 are essentially useless, as I've shown you. But again, these tests will improve purely because of their biochemical response. And of course, you do see some improvements in stiffness, which doesn't necessarily equate to a regression of cirrhosis. So just be careful, particularly of those patients post-SVR when you follow them. So what about fibrosis progression? Very quickly, EPIC, for those of you who remember, these were HCV non-responders, Medivir F2 to 3. They got randomized to receive low-dose PEG-2B or observation, and then had another biopsy. And a proportion of 250-odd patients had paired biopsy and FibroTest. And just briefly, you can see on the vertical axis, this is FibroTest difference, and Medivir stages changed in this period of time, as you'd expect, in these non-responders. But FibroTest did not change. And while I have a couple of minutes, this was the largest antifibrotic study in prior to the NASH studies. This was a PPAR gamma agonist we undertook in Hep C non-responders with Ishak stages 2, 3, and 4, so the mild to moderate stages. And again, it was a negative study, but the idea was we got paired biopsies at obviously week 0 and then week 52. There was no changes in Ishak stage at week 52, but what we did find was that these HCV non-responders did have progression in, when you look at their collagen, quantitative collagen staining, and their alpha smooth muscle actin. Smooth muscle actin is a marker of fibrogenesis because it measures hepatic stellate cell activation immunohistochemically. And we saw some changes in that regard, but FibroTest, again, did not change. Just wasn't sensitive enough to follow these changes in fibrogenesis. But what we did get out of this study was the idea that within each matrix, each protein, there are various neoepitopes, various cleavage fragments, if you like. So if you take the type 3 collagen, for example, you'll see a lot about in the NASH studies the P3MP, which is one of the key components of the ALF panel. But within that P3MP, you'll see different components such as C3M, which reflects matrix degradation, or ProC3, which reflects matrix formation. And so we thought we'd apply this to that negative study, which I just showed you. And we actually found that both ProC3 and FibroTest actually do associate with baseline Ishak score, which isn't surprising. But only ProC3 was independently associated with fibrosis progression. And you now see ProC3 adapted into various marker panels, and particularly in the NASH field as well. So again, last slide, summary of current non-invasive tests. Diagnostic, yes, it's possible for cross-sectional diagnosis of cirrhosis and mild stage disease. If you're looking at splitting broad categories, yes, it's possible. FibroScan, FibroTest, or any of the serum markers, if they all agree, it's great. Not reliable for the diagnosis of those intermediate stages, so F2, particularly F2 to F3. Not reliable for separation of adjacent stages, as I've shown you. What about fibrosis progression, regression? There are no validated serum markers or imaging methods which will help you reliably assess fibrosis progression or regression. Prognosis, I didn't get a chance to get into this. These are useful surrogate markers of clinical outcomes. And Dr. El-Sarraj showed you some utility in predicting patients' risk of HCC, for example. Risk prediction, I didn't have a chance to go into this, but there was a lot of interest in developing genetic risk predictors using the Celera CRS score, cirrhosis risk score, and FibroGene, etc., which incorporate IL-28B into their prediction model. But again, these have fallen by the wayside and are not routinely available. And importantly, there is no validation or no risk predictors. These genetic markers have not been validated post-SVR, and there are no real prognostic or risk predictor variables which correlate with fibrosis post-SVR. That's the last slide. Thank you.